Good evening and welcome. I'm Dr. Mark, and I've spent over 10 years in clinical practice working closely with adults over 60, helping them navigate medications, chronic conditions, and healthy aging. On my channel, Dr. Mark Hyman Official, my goal is simple: to help you make informed, safe, and confident health decisions. Today's topic is important and often misunderstood. 35 prescriptions doctors secretly avoid after 65. Now let me clarify something at the beginning. This is not about fear. It's not about saying these medications are bad. Many of them are useful and even life-saving in the right situation. But after age 65, the body changes. The way medications are absorbed, metabolized, and cleared shifts significantly. Kidney function may decline. The liver processes drugs more slowly. Body fat composition changes. The brain becomes more sensitive to certain chemicals. And most importantly, many seniors take multiple medications at once, increasing the risk of interactions. Because of these factors, experienced clinicians often avoid or use extreme caution with certain prescriptions in older adults. Let's break this down clearly and practically. First, strong sedatives and sleeping pills. These include medications like zolpidem, azopiclone, and similar drugs used for insomnia. While they may help someone fall asleep quickly, in older adults they often cause confusion, memory problems, and nighttime falls. A fall at 70 is very different from a fall at 30. Hip fractures and head injuries can change a life permanently. Second, benzodiazepines such as diazepam, alprazolam, lorazepam, and clonazepam. These medications are commonly prescribed for anxiety or sleep. In seniors, they significantly increase the risk of cognitive impairment, slowed reaction time, balance problems, and dependence. Long-term use is strongly discouraged unless absolutely necessary. Third, strong anticholinergic medications. This is a large category that includes certain antihistamines like diphenhydramine, some bladder control medications, and older antidepressants such as amitriptyline. These drugs block acetylcholine, a neurotransmitter essential for memory and cognition. In older adults, they are strongly associated with confusion, constipation, dry mouth, urinary retention, and increased dementia risk. Fourth, certain muscle relaxants like cyclobenzaprine and carisoprodol. These medications can cause heavy sedation, dizziness, and increased fall risk without providing significant long-term benefit for chronic pain. Fifth, long-acting sulfonylureas such as glyburide used for diabetes. These can cause prolonged hypoglycemia in older adults. Low blood sugar episodes are extremely dangerous after 65, increasing the risk of falls, heart strain, and hospitalization. Sixth, sliding scale insulin without proper monitoring. Overly aggressive glucose control in seniors can cause more harm than benefit. Stability is often safer than perfection. Seventh, long-term NSAIDs such as high-dose ibuprofen or naproxen. These raise the risk of stomach bleeding, kidney damage, and cardiovascular events. Eighth, certain opioids, particularly long-acting formulations. While pain management is important, these drugs increase the risk of sedation, falls, constipation, and respiratory depression. Ninth, certain antipsychotics when used for behavioral symptoms in dementia. These carry increased risk of stroke and mortality in older adults. 10th, some antiarrhythmic medications like amiodarone when safer alternatives exist due to long-term toxicity risks affecting thyroid, lungs, and liver. 11th, certain alpha blockers used for blood pressure such as doxazosin. These can cause orthostatic hypotension, leading to dizziness and falls. 12th, clonidine for blood pressure, which may cause rebound hypertension and sedation. 13th, certain tricyclic antidepressants including imipramine and doxepin at higher doses. 14th, long-term proton pump inhibitors without clear indication. These have been linked to bone loss, kidney issues, and infections when used indefinitely. 15th, megestrol for appetite stimulation. It increases the risk of blood clots and has limited long-term benefit. 16th, certain anti-nausea medications with strong dopamine-blocking effects that can cause movement disorders. 17th, strong corticosteroids used long-term without monitoring. These can worsen osteoporosis, blood sugar control, and immune function. 18th, certain older antihypertensives that significantly lower blood pressure too aggressively. 19th, combination medications that duplicate ingredients, increasing overdose risk unintentionally. 20th, certain bladder antispasmodics with heavy anticholinergic burden. 21st, high-dose digoxin above recommended levels for older adults. 22nd, certain antifungal medications that strongly interact with heart and cholesterol drugs. 23rd, long-term use of certain antibiotics without clear need, increasing resistance and gut imbalance. 24th, hormone therapies started late in life without strong indication. 25th, certain migraine medications that constrict blood vessels in individuals with vascular disease. 26th, excessive thyroid hormone dosing leading to bone and heart complications. 27th, certain weight loss stimulants. 28th, strong appetite suppressants affecting heart rhythm. 29th, combination cold medications containing sedating antihistamines. 30th, certain seizure medications at higher doses without monitoring blood levels. 31st, overly aggressive cholesterol therapy in frail elderly without cardiovascular history. 32nd, long-term dual antiplatelet therapy without reassessment. 33rd, certain chemotherapy agents in patients where risks outweigh quality of life benefit. 34th, medications causing significant sodium imbalance. 35th, any medication that no longer aligns with the patient's life expectancy, goals, or overall health priorities. Now, here's the most important message. This is not about automatically stopping medications. It's about regular review. Every adult over 65 should have a structured medication review at least once a year. Each drug should answer 3 questions. Is it still necessary? Is it still safe at this dose? Does the benefit clearly outweigh the risk? Deprescribing, carefully reducing or stopping unnecessary medications, is one of the most powerful tools in geriatric medicine. Studies show that reducing inappropriate medications improves cognition, reduces falls, and enhances quality of life. After 65, healthcare goals often shift. The focus becomes maintaining independence, preventing falls, protecting brain function, and maximizing comfort, not chasing perfect lab numbers. Polypharmacy, meaning taking 5 or more medications daily, dramatically increases complication risk. The more prescriptions someone takes, the higher the chance of drug-drug interactions. Even well-intentioned prescriptions can accumulate into harm over time. Experienced clinicians understand that sometimes the safest prescription is fewer prescriptions. If you or a loved one is over 65, I encourage you to request a full medication review. Bring every pill bottle, including supplements. Ask whether each medication is still essential. Ask whether doses can be lowered. Ask about safer alternatives. Aging changes physiology. What worked at 50 may not be appropriate at 75. The goal is not fear. The goal is thoughtful, individualized care. Thank you for joining me on Dr. Mark Hyman Official. Stay informed, stay proactive, and always make healthcare decisions based on balanced evidence and personal health goals.